Okay, good morning. So this is our last session for the hematology lecture. So we are now going to discuss about the different laboratory procedures in hematology. Okay, so first we have the improved Neubauer ruling on the hemocytometer. So still in the ASCP exam, there are still questions about cell count. I even had one during my exam. So it's important that we know the dimensions of the hemocytometer and in where uh, in which part of the hemocytometer certain cells are being counted. Okay, so first we have our WBCs. Okay, so WBCs are usually counted in the four corner squares. However, that depends on the dilution that is being employed. So routinely, routinely the dilution for WBC count is 1:20. And if the dilution is 1:20, that is usually counted in the four corner squares. Okay. However, there is an option to employ a 1:100 dilution. And if this is the dilution, usually white blood cells are counted in all 9 squares, okay? Of course, in both sides of the hemocytometer, okay? So, what is the volume, okay? What is the volume of one, okay? Corner square or one secondary square in the hemocytometer? Okay, so we could solve for the volume by multiplying, of course, the dimensions of this particular square. So that would be, okay, 1 mm by 1 mm by 0.1 mm. Okay, so the 0.1 mm, that is the standard depth of our hemocytometer. Okay, so that makes, one square 0.1 mm cube, okay, or UL 0.1 mm cube or 0.1 microliters in volume. Next, we have the red blood cells. So red blood cells are usually counted in the 5 squares that are found in the central large square of the hemocytometer. So they are in they are the ones in blue. Okay, so what would be the volume? Okay, so what would be the volume of one RBC square? So the volume is 0.2 mm times 0.2 mm times 0.1 mm. Okay, so that makes the volume of one RBC square as 0.004 cubic millimeter or 0.004 microliters. So usually for the red blood cells, we could employ the 1:100 or the 1:200 dilution. Okay. And lastly, we have the platelets. The platelets are counted in all, okay, in all 25 squares in the central large square. Okay, so having said that, it's like you are counting the entire central large square. So typically, the dilution that is employed for platelets is 1:100. Okay, this is the typical dilution, okay, for platelet count. And since you are counting the entire, okay, central large square, so that makes the volume, okay, as similar with that of one WBC square. So that's 1 mm times 1 mm times 0.1 mm. Okay, so the volume is also 0.1 mm cube or 0.1 microliter. Okay, so usually for the platelet count, the gold standard or the reference method for this employs the use of the phase contrast microscope. Okay, because we know naman that platelets are really small, okay, and because of that, their refractive index is low. So it's really difficult for them to be seen under the usual bright field microscope. So based on the method that is specified by Brecker and Cronkite, Brecker, and Cronkite. So that is the method that makes use of 0.1% ammonium oxalate and employing the use of the phase contrast microscope. Okay, so we have a general formula, okay, for the cell count using the Neubauer ruling. So this formula, it's really safe, no, to use this formula as long as you know the dimensions of the hemocytometer. Provided all you have to do is to place the cells counted on both sides. Okay, the dilution factor. So the dilution factor is automatically the denominator of the dilution, provided the numerator is 1. And the total volume in the chamber counted. So how do we derive the total volume in the chamber counted? We derive this from multiplying the number of squares counted, okay, the number of squares counted, okay, times the volume, okay, the volume of 1 square. Okay, the volume of 1 square. So here, we just need to be careful on what are the values given to us, because sometimes they would say that they would give you the average of the count on both sides. So if that happens, let's say for example, okay, in the case of the RBC count, for example. So they might give you, let's say, the average of the RBC counted, let's say, is 250. So usually when you say average, that is already the average of the counts on both sides. So that means if we are counting, let's say, for example, if we are counting 10 squares in all, diba? Because 5 squares on both sides. So we are counting 10 squares all in one hemocytometer. So if the value given to you, or if the cell count given to you is already in average, that means you also have to get the average of the numbers of squares counted. So instead of placing 10 here in the number of squares counted, you will only place 5. Kasi ibig sabihin, since average is the one given to you, that means hinati na sa dalawa yung cells counted. So that means hahatiin mo din sa dalawa yung number of squares counted. Okay? So I think that's the only challenge there, okay? To be vigilant, no, on what are the values given to us, no, for the cell count. Okay? Next, we go to the corrected WBC count. So remember that whenever there are presence of nucleated red blood cells, okay, in the peripheral blood smear, okay, that entails the performance of the corrected WBC count. Sa katunayan, okay, you have to do the correction if at least 5 nucleated red blood cells, okay, were seen in the peripheral blood smear. Okay. Now, why do we have to do the correction for the WBC count? This is for the reason that nucleated red blood cells are actually counted as white blood cells. Okay, so it could falsely increase. No, the presence of these nucleated red blood cells could falsely increase, okay, the WBC count, and thus we have to correct for that. Okay. However, no, yung isang recall question in the ASEP exam was parang tinanong siya, no, to do the corrected WBC count, but instead of doing the 100 cell differential, yung usual na differential count na ginagawa natin is we are checking 100 white blood cells and we are differentiating them. Okay, however, sometimes if the cell count is low, if the WBC count is low, it's difficult for us to reach 100 cells, di ba, for the differential count. So minsan we opt for the 50 cell differential. Ito lang guys yung tandaan natin, that if the differential count that is done is a 50 cell differential, papalitan din natin yung formula. Instead of the usual 100, papalitan natin siya guys ng 50. Okay? So yan lang, no, for the corrected WBC count. Again, usually we do the correction, okay, pag meron ng at least 5 nucleated red blood cells present in the peripheral blood smear. Okay? So now punta tayo guys, no, sa ating electronic impedance counters. Okay? So of course, electrical impedance is one of the basic principles or the basic methods used in automated cell counting. Sa katunayan, dalawa yan sila eh. We have the electrical impedance and the other one is the optical light scatter. Okay, lagay ko dito sa baba. Okay, we have electrical impedance. Okay, electrical impedance, and we have the optical, okay, or the light scatter. Okay, so these are, okay, the basic principles. Okay, the basic principles or the basic methods, okay, used in automated cell counting. Okay? So, usually, no, kailangan mag-partner itong dalawang ito because one thing that we have to know about electronic impedance or electrical impedance is it can only differentiate cells based on their size. So, kumbaga yan lang yung only basis ng electrical impedance to be able to discriminate or differentiate cells from each other. Okay? So usually, hindi niya na-assess yung internal complexity ng cell. Okay? So the basic principle of electrical impedance is that our cells do not conduct electricity. So whenever they are being whenever they are made to pass through a certain aperture, they will create electrical resistance. They will create voltage pulses. Okay? Now, these voltage pulses, no? These pulses, okay, the number of the pulses corresponds with the cell number. Okay? This corresponds with the number, okay, the number of cells. Okay? And take note natin that the amplitude or yung laki or yung height, kumbaga, no, yung height ng pulse or the amplitude of the pulse, okay, the amplitude of the pulse, okay, corresponds with cell size. Okay? So, in electrical impedance or electronic impedance counters, white blood cell count, okay, which is being performed, of course, in the WBC aperture, okay, these are particles that are 35 femtoliters above. So here, tatandaan natin that the WBCs and the red blood cells are counted in a different aperture. Kasi baka ma-confuse kayo. How come that white blood cells are counted? How come that particles larger than 35 femtoliters are only counted as WBC? Well, in fact, red blood cells belong in a range of 36 to 360 femtoliters. That is because they are counted in different apertures. Okay? So for the WBC count muna, okay, yung mga lymphocytes or small mononuclear cells are the ones counted between 35 to 90 femtoliters. Large mononuclear or monocytes, nasa 90 to 160 femtoliters sila. And yung mga neutrophils natin and the other granulocytes, namely yung eosinophil at basophil, they are in the range of 160 to 450 femtoliters. Okay? Yung red blood cell is of course counted in the RBC aperture. What's the difference between the two? Okay? For the WBC aperture, okay, the specimen is mixed with a diluent and a lysing agent. Okay? Of course, the purpose of the lysing agent is to lyse, okay, to lyse red blood cells because you do not want red blood cells to be counted here, di ba, in this aperture. Okay? Yung concern lang natin dito are the white blood cells. So we have to lyse the red blood cells so that we can only count the WBC. Okay? Also, in the same aperture, this is where hemoglobin is being determined. Okay? And hemoglobin determination is usually determined still based on the cyan-met, okay, the cyan-met hemoglobin, okay, cyan-met hemoglobin reaction or method. Okay? So yan. And this is the very reason why earlier, no, when we talk about the cell counts, okay, we have to correct, okay, for the presence of nucleated red blood cells because pag yung isang red blood cell nucleated, hindi siya nasisira. No, pagpasok ng RBC dito sa ganitong aperture and whenever they are exposed to the lysing agent, they are not actually being lysed because these red blood cells, they resist, no? They resist lysis. So they are counted as WBC, which is why we have to correct for the WBC count. Okay? Then lastly, our platelets are counted in the same aperture with our red blood cells. And platelets are those ranging from 2 to 20 femtoliters. Okay? So dito naiintindihan dapat natin that the electrical impedance instrument is only able to differentiate cells based on their size. Nalalaman natin yung kanilang size based on the height, based on the amplitude of the pulse that they create. Okay? So yan po yung ating electrical impedance. Now, how do we discriminate? Let's say for example, yung mga white blood cells, no? Because for example, yung ating mga granulocytes, they tend to belong in the same range when it comes to electric impedance instrument. Now, how do we distinguish them from each other? Diyan pumapasok guys yung usefulness nitong optical or light scatter. Okay? Because in the case of the optical or light scatter, okay, meron kasi tayo ditong tinatawag na forward tsaka side scatter. Okay? So, pag sinabing forward scatter, okay, pag sinabing forward scatter, usually para ito, no, this measures the cell size. And yung side scatter, okay, the side scatter or yung 90 degrees angle scatter, or tinatawag din ito guys na orthogonal scatter. Okay, orthogonal scatter. This one naman assesses cellular, okay, cellular granularity, okay, granularity, or pwede din siyang tawaging cellular complexity. Okay? So dito na guys pumapasok yung number of lobes ng nucleus, yung presence ng mga cytoplasmic granules. Okay? So that's it for our electric impedance. Now, punta tayo no sa ating mga red blood cell indices. So we have three. We have MCV, MCH, and MCHC. And tatandaan natin that MCHC is the red blood cell index that is not used. Okay, not used for the morphological classification of anemia. Okay, morphological classification of anemia. Okay, so usually we are only using MCV and MCHC, di ba? Now, for MCV, okay, ano yung formula natin dito? This is very important. Okay, hematocrit, okay, hematocrit in percent, okay, divided by your red blood cell count, yung red blood cell count mo in times 10 to the 12 per liter times 10. Okay, so that's a formula for the MCV. And what is the normal value for MCV? That is 80 to 100 femtoliters. Okay, 80 to 100 femtoliters. So that means those red blood cells that are below 80 femtoliters, they are referred to as microcytic red blood cells. And those that are above 100, they are the macrocytic RBCs. Okay? Now, formula naman natin for MCHC. MCHC guys is hemoglobin. Okay? Your hemoglobin, that should be in grams per DL. Okay, divided by your RBC count, okay, times 10, okay, times 10. And take note that your mean cell hemoglobin indicates the average weight of hemoglobin per, take note, per red blood cells, okay, per red blood cell. Okay, so what is the normal value for our MCH? Normal value, guys, is 26, okay, 26 to 32 picograms. Okay, 26 to 32 picograms. Okay, and lastly, we have the mean cell hemoglobin or mean cell hemoglobin concentration or mean corpuscular hemoglobin concentration. So this one naman, okay, represents the average concentration of hemoglobin per 100 ml of packed red blood cell. Okay, so yan yung difference ng dalawa. Pag per red blood cell, mean cell hemoglobin. Pag per 100 ml of packed red blood cell, that is the mean corpuscular hemoglobin concentration. Okay, so ano naman yung ating formula for this? This is hemoglobin in grams per DL divided by your hematocrit, that should be in percent, okay, times 100. Okay? And what is the normal value? Okay, what is the normal value for our MCHC? That is 32, okay, to 36, okay, grams per DL. 32 to 36 grams per DL. Okay? So usually, if below 32 grams per DL yung kanyang MCHC, so yan yung mga tinatawag natin na hypochromic, no? Hypochromic RBC. Whereas those that are above 36, they are the ones referred to as hyperchromic RBC. However, itong pagiging hyperchromic, it seems to be para siyang misnomer. Because technically, one RBC could not contain more than 36 grams per DL of hemoglobin. Technically, ganun yun. Okay? Which is why, if the value for your MCHC is already 36 to 38, 36 to 38 grams per DL, you have to check for the presence of spherocytes, spherocytes in your peripheral blood smear. Kasi usually, if meron tayong anisocyte, meron tayong poikilocyte rather that is having a hyperchromic characteristic. These are our spherocytes. Now, if the hemoglobin or if the mean cell hemoglobin concentration is already greater than 38 grams per DL, we have to check now for possible errors, errors in hemoglobin determination. Okay? I-check natin yung mga possible errors in hemoglobin determination. Kasi yan lang naman usually yung magiging reason in order for the MCHC to go beyond 38 grams per DL. Okay? So yan po yung ating mga red blood cell indices. Okay? So let's go to our histograms. So a histogram utilizes impedance technology, and it is a representation of the cell number versus one measured property. And since impedance yung technology, usually that property is the cell size. Okay? So we have our different histograms for the different cellular population. So first, we have our WBC histogram. So this corresponds to the volume of our white blood cells. Na sabi natin kanina, these are the cells that having a mean cell volume of 35 to 450 femtoliters, which is being counted in the WBC aperture. Okay? So for the WBC histogram, meron siyang tatlong peaks. Okay? So here are the peaks. One, ito. Tsaka ito, these are the peaks, okay, of your WBC histogram. And these peaks actually represents different cellular populations. Okay? So for the first peak, okay, this represents our lymphocytes. Okay? They represent our lymphocytes, and these are usually the ones, okay, having 35 to 90 femtoliter mean cell volume. Okay? The second peak represents the monocytes, okay? The monocytes with a volume of 90 to 160 femtoliters. And lastly, the third peak, this represents the granulocytes, okay? The granulocytes with a volume of 160 to 450 femtoliters. That's why kung makikita natin dito, medyo yung nasa dulo, medyo broad siya, considering the several populations of our granulocytes. Okay? Now for our RBC histogram, so this is 36 femtoliters and above is the reference size range for our red blood cell. Okay, remember this cannot be confused with white blood cells because our red blood cells are counted on in a different aperture. Okay? So dapat normally yung ating RBC histogram will only show one peak. Okay? It will only show one peak between the 70 to 110 femtoliters that will correlate with the range, the usual range of our red blood cell mean cell volume. Kasi 'di ba yung mean cell volume natin for RBC, yung normal nasa 80 to 100 femtoliter. Okay? So the width, okay, again, the width of the peak or the width of this graph or peak no, corresponds again to the sizes, okay, the sizes of or the size range of our RBC. Okay, so syempre if let's say for example yung histogram mo naging ganyan, yung peak, yung width niya lumaki, that means you have a wider range of RBC sizes, and that will correspond with what we call the red cell distribution width. Kasi 'di ba, pag sinabi nating red cell distribution width, that talks about the size variation of our cells, of our red cells. So if the width is increased, that means no, increase din yung red cell distribution width. That could sometimes indicate presence of anisocytosis, no? A variation in your red blood cell sizes. Okay, anisocytosis. Next, we have the platelet histogram. So the platelet histogram is occurring before the RBC histogram. So that is for the particles ranging from 2 to 20 femtoliters for the platelets. Okay, so again, this one is occurring before the start of the RBC histogram. Okay, now let's go to the different abnormal histograms and ano yung mga possible indications nila whenever they are present. Okay, so first for our WBC histogram. Now, if you have a population before, okay, before 35 femtoliters, usually this indicate presence of nucleated, okay, nucleated red blood cells, okay, or possible presence of giant, okay, giant or clump platelets, okay, giant or clump platelets. Next, if there is a peak overlap of 90 femtoliters, usually this is because of the presence of reactive lymphocytes, okay, reactive lymphocytes, or yung mga or also presence of blast cells. If there is a peak overlap at 160 femtoliters, usually this is because of an increase, okay, increased number of bands, okay, or increased number then of other, okay, immature granulocyte forms. Okay, and if there is a population after 450 femtoliter, usually this is due to a high, okay, a high granulocyte count. Now for our abnormal RBC histogram, if you have two peaks, so obviously this could indicate a dimorphic, okay, dimorphic, okay, RBC population. Dimorphic red blood cell population. So, ano yung mga possibilities, no, para magkaroon tayo ng dimorphic RBC population? So, dalawa, no? Dalawa. Pwede that you have two deficiencies occurring, no, in your body. Dalawa yung deficiencies mo. Maybe one deficiency is resulting to smaller RBCs and the other deficiency is resulting to big red blood cells population. Okay, so pwede guys, let's say for example, no, ang malas mo naman pag nagkaroon ka nito. Let's say meron kang iron deficiency anemia and at the same time meron kang vitamin B12 deficiency. So alam naman natin that IDA would result to microcytic red blood cells and the vitamin B12 deficiency would result to macrocytic red blood cells. So that's one possible reason for having a dimorphic RBC population. Or another is in cases of post-transfusion, okay, post-transfusion, or pwede din natin tawaging post-therapy, okay, post-therapy, okay? Let's say for example, no, you have iron deficiency anemia. So if you have iron deficiency anemia, di ba usually meron kang mga microcytic red blood cells, okay? So that is responsible for one peak already. Now, you are given iron supplementation. So because of that, okay, na-correct na yung tamang morphology, no, ng mga red blood cells mo. So you now have the normal red blood cell morphology, the normal red blood cell size, which will create the normal peak. Okay? So hindi naman na automatically lahat ng mga microcytic RBC mo will be converted already into the normal sizes, 'di ba? So that's the reason why no na meron kang dalawang possible peaks no in cases of post-transfusion or post-therapy. Okay? Now, let's go to increase curve width. No, yun na yung sinabi ko kanina na pag yung width lumaki, let's say it goes beyond the 70 to 110 width that is usual, okay? That means increase yung RDW mo or yung red cell distribution width mo. And this indicates presence of anisocytosis. Okay? Anisocytosis or defined as the variation in cell size. Next, if there is shift to the right or shift to the left, no? Yung shift to the right or shift to the left, titingnan mo guys yung kung saan nakikita yung peak in relation to the mean of your mean cell volume. Okay? So let's say for example, if the mean cell volume, the normal mean cell volume is 80 to 100 femtoliters, that makes 90 femtoliters as the peak, no, of your RBC curve. Okay? Now, pag sinabi nating shift to the left, unahin muna yung shift to the right. Pag sinabi nating shift to the right, that means lumalaki yung red blood cells mo. Kasi papunta siya sa right eh. So papunta siya sa right ng 90, no? Papunta siya sa right ng 90 if you are sa right mo, no? If you are facing the so for example, ito, dito tayo. So for example, ito. So 100 yan, no? So let's say this is the 90. Okay? So pag papunta siya dito, that is shift to the right. Okay? So that means lumalaki yung sizes ng RBC mo. Pag papunta siya dito, that is shift to the left. Lumiliit yung sizes ng red blood cells mo. Okay? So yan lang naman, no? Yung shift to the left and shift to the right. Okay? So shift to the right, pakilagay dyan, no? This is in relation no, to the peak no, of your RBC histogram. So if shift to the right, tumataas yung mean cell volume mo. So this could indicate presence of macrocytes. Okay? Pag sinabi naman natin guys na shift to the left, bumababa yung mean cell volume. So this could indicate presence of microcytes. Okay? Okay? So let us proceed to the conditions that cause interferences on most hematology analyzers. Okay, so actually I only included here no yung so far no yung mga medyo high yield no in the ASCP exam. Okay, however there is one table in the book of Rodak indicating all of these interferences no. So maybe you know I would advise you to check out the table. Okay, or maybe I'll just post that as I'll just snip and post that particular table no, in our review page or review group rather. So what I've included here are the common ones. Okay, so first we have the presence of cold agglutinins. Okay, so example of cold agglutinins are the anti-small I, okay, and the anti-big I. Okay, they are the known, no, mga known cold agglutinins that are usually produced because of a certain infection. So how will the presence of cold agglutinins affect no, the reading of your hematology analyzer? Okay, so your red blood cell count will be decreased. Okay, decrease yung RBC count mo and increase yung mean cell volume mo. Decrease RBC count and increase mean cell volume. So what is the rationale for this? Of course, no, as what I've mentioned earlier, our hematology analyzer are able to discriminate cells based on their size. So what will happen if there are cold agglutinins? The red blood cells will clump. They will agglutinate with each other. And since they agglutinate with each other, instead of them being counted individually, they are counted as one big RBC, which is why the count is decreased and the size is increased. Kaya tumataas yung MCV. Okay? So usually, ano yung magiging indicator natin dito? Okay? Since tumataas yung MCV, the indicator would be seen in the histogram. There will be a shift to the right, okay? A shift to the right, okay? In the RBC histogram. Okay, shift to the right in the RBC histogram. So that is our indicator, okay, for the presence of cold agglutinates. Okay, so now what would be our remedy? We are to warm the specimen in order to inactivate the cold agglutinates, and we rerun the sample. Okay, and rerun. Okay, warm the specimen and rerun the sample. Okay. Next is presence of lipemia, icterus, and chylomicrons. Of course, chylomicrons are known causes of sample lipemia. Okay, so how will they affect, okay, the analyzer, the result of the analyzer? This will increase your hemoglobin determination. Okay, and of course, the hemoglobin dependent indices will also be increased, no? Yung MCHC tsaka yung MCH. Yeah. Okay, so what will be our indicator here? Okay, our indicator is yung hindi na nagtutugma yung ating rule of 3. Sa katunayan kasi guys, yung rule of 3, it could serve as a quality control means para sa atin. Okay? Kasi if let's say for example, no, as long as the morphology of the cells are normal, the morphology of the red cells are normal, okay? Dapat nagtutugma parati itong ating rule of 3. Okay? So if there are technical errors, the rule of 3 will not coincide. So in the case of the presence of lipemia, icterus, and chylomicrons, your hemoglobin, di ba, yung rule of 3, hemoglobin times 3 dapat is equal to hematocrit. But if meron ganitong mga technical errors, your hemoglobin times 3 will not equalize to the hematocrit value. Okay, so what is our remedy here? We are going to replace the plasma. Kasi yung problema nasa plasma. Okay? Next up, we have presence of lysis-resistant red blood cells with abnormal hemoglobin. So usually, what are the abnormal hemoglobins that makes the cell resistant to hemolysis? We have hemoglobin S, hemoglobin C, and hemoglobin F. No? So this makes our red blood cell resist lysis. And since they resist lysis doon sa ating WBC aperture, for example, since hindi sila nalalyse, they will be counted as WBC. Okay? They are counted as WBC. Eventually, increasing your WBC count, okay? Increasing your WBC count, also increasing your hemoglobin value. Okay? So usually, our indicator here, okay, is a flagging or an interference in the histogram. Okay, interference on histogram. Okay, so what would be our remedy? We are to make a manual dilution. Okay, a manual dilution. Maybe we could adjust the tonicity of our lysing agent, make it more hypotonic, for example. Okay, make it more potent or stronger in order for it to lyse the lyse-resistant red blood cells. Okay. Actually, there is a recall question about this. Okay, it's para siyang scenario wherein nag-perform yung medtech ng WBC count, and the first WBC count using a particular diluting agent gave a high WBC count. No? Mataas yung WBC count. So what the medtech did was pinalitan niya yung lysing agent. And after replacing the lysing agent, bumaba yung WBC count. So that means bumaba yung WBC count because what contributed to the higher WBC count in the first count was the lyse-resistant red blood cells, which were counted as WBC. That's why when the procedure made use of a stronger diluting agent, those lyse-resistant red blood cells will already lysed and they are no longer counted as white blood cells. That's why na-correct na yung count after employing the use of a higher or a stronger diluting agent. Next up, we have presence of platelet clumps. Okay, so still, no, we are differentiating cells based on their size, and if the platelets will clump, okay, para lang din silang mga RBC na nag-agglutinate kumbaga. So they are not counted individually, they are counted as a whole kumbaga. So that means your platelet count will be decreased. Okay, your platelet count will be decreased. And these platelet clumps will be counted as WBC. So your WBC count will be increased. Okay, so of course, this will be indicated, no? This will be indicated by presence of an interference, okay? Interference on histogram. Yeah. Okay, interference on histogram. So what would be our remedy for this? Okay, for the presence of the platelet clumps. Sometimes guys, no, we could associate this with what we call the platelet satellitis. No, pwede din natin tong ma-associate, no, sa platelet, okay, satellitis. Okay, pero in the case of the platelet satellitis naman, yung mga platelets mo are not counted because they tend to adhere to your granulocytes or to your neutrophil, for example. Okay, so in the case of platelet satellitis, our specific remedy for that is we are going to collect, okay, collect a new specimen, okay, collect a new specimen, usually using citrate as our anticoagulant. Kasi yung platelet satellitis, this is induced by EDTA. Okay? And multiply result, okay, multiply result by 1.1. Next up, we have presence of hemolysis. Okay, so of course, when the red blood cells are already lysed, they are not counted as red blood cells anymore kasi syempre nasisira na sila, 'di ba? So the RBC count, no, the RBC count will be decreased. Okay? Decrease yung RBC count mo. Okay? And your hematocrit is increased. Okay? Magiging increase yung hematocrit mo because remember guys that the hematocrit is a derived value. Hematocrit is not being measured directly by our analyzers. Instead, hematocrit is only solved based on your RBC count and the mean cell volume. Lagay ko dito sa baba, paano daw diniderive yung hematocrit value for our analyzers. Hematocrit is derived, okay, is derived from RBC count, okay, RBC count, and the mean cell volume. So take note natin na itong RBC count and mean cell volume, they are directly measured parameters by our hematology analyzers. Okay? So again, the rationale here is red blood cells were already lysed, so they are no longer counted as red blood cells. Okay? So what would be our indicator here? Okay? Yung hindi na naman nagko-coincide yung ating rule of 3. Okay? So the hemoglobin, no, the hemoglobin times 3 will not be equal to your hematocrit value. Okay? So usually, no, because of that, the presence of hemolysis will give us a similar histogram picture with lipemia. Paki-indicate, okay? This will usually give us a similar, okay, histogram picture with presence of lipemia or chylomicrons. Okay? So what will be our remedy here? Siyempre, lyse na yung specimen. Wala na tayong magagawa dyan. So request a new, okay, request a new specimen. Next, presence of microcytes or schistocytes. So these microcytes and schistocytes will not be counted as red blood cell anymore. Pag maliit sila, no, they might not be counted as red blood cells. They might be counted as platelets already. So magiging mababa yung RBC count. Okay, magiging mababa yung RBC count, pero tataas yung platelet count. Okay, tataas yung platelet count. That is because these microcytes and schistocytes were now counted as platelets. Okay? So what will be our indicator? Okay? Yung indicator natin dito, ano yon? Since maliliit yung mga microsites sa schistocytes, it will show a shift to the left, no? Or a left shift. Okay? It will show a left shift, okay, on your RBC histogram. On RBC histogram, okay, and abnormal platelet histogram. Abnormal platelet histogram. Okay, so how do we make our remedy here, or how do we confirm that there are really presence of microsites or schistocytes? Of course, you are to look at the blood film. So review the blood film. Okay. Next and last, no, for these technical errors, we have nucleated red blood cells and megakaryocyte fragments. Okay? However, ito usually yung mga ganito na interference, they tend to be present already or present only sa ating mga old hematology analyzers. Okay, because the newer analyzers, they are actually they are already adapted, no, or they are already capable, no, of counting nucleated red blood cells. And these analyzers are now able to perform the corrected WBC count themselves. Okay? But for old analyzers who are not capable of doing that, the presence of nucleated red blood cells and megakaryocyte fragments will result to an increase in your WBC count. For the very reason that these nucleated RBC and these megakaryocyte fragments are counted as white blood cells. Okay? So, now, again, no, ulitin ko yung point ko dito that this will only affect, no, the old hematology analyzers because this particular interference is already corrected by newer instruments. Okay, because they are able to count, no, nucleated red blood cells already. Okay, so those are just some, no, of the interference that we need to know, okay, about our hematology analyzers. So let us now proceed to reticulocyte count. Reticulocyte count, take note natin parati, is the indicator of the bone marrow response. Of the bone marrow response. Ano yung ibig ko sabihin, no, sa bone marrow response na ito? Okay? Whenever we have anemia, you have less amounts, diba, of red blood cells. So technically, if your bone marrow is okay and there's nothing wrong with the production of RBC, the bone marrow will respond by releasing a lot of reticulocytes. Okay? Thus, the reticulocyte count is very important. No? If you could recall our topic on the differentiation of anemia, the reticulocyte count is the very first test that you have to perform in order for you to determine ano ba yung cause ng anemia. Is it because you are not producing RBCs, or is it because your RBCs are destroyed or RBCs are lost in a faster rate? Okay, so usually if the problem causing anemia is a defective production of RBC, your reticulocyte count will be low because your bone marrow is not responding normally to the presence of anemia. But if the cause of anemia, okay, if the cause of anemia is because of increased blood loss or because of increased red blood cell destruction, nothing is wrong with the bone marrow. So your bone marrow will respond to it by releasing reticulocytes, thus increasing your reticulocyte count. Okay? So here, okay, this is a picture of your reticulocyte count under the right stain smear. So take note that your retics, they can actually be seen under the right stain smear. They will appear as polychromatic macrocytes. However, we all know that the requirement, no, the standard in order for us to reliably count our reticulocyte is supravital staining. So either we could employ the use of the new methylene blue or brilliant crescel blue. Okay? So there are different formula, okay, for or there are different reticulocyte counts, and each of them, no, meron silang mga kanya-kanyang significance, no, or kanya-kanyang usefulness or diagnostic usefulness. Okay, so yung pinaka-common na ginagawa natin is the relative count. Okay, and what is the formula of the relative count? So this is your retics in percent, no, retics, okay, in percent. Okay, so this is number of reticulocyte count of retics counted divided by 1,000 red blood cells. Okay, 1,000 red blood cells times 100 kasi syempre in percent. So this particular counting uses, no, it uses a Miller disc. Okay, in order for you not to be able to in order for you not to literally count 1,000 RBC, gumagamit tayo ng Miller disc in order to hasten this particular procedure. Okay, so what is the normal value for the relative reticulocyte count? That is 0.5 to 1.5%. Okay, but of course, this value is higher in newborns or neonates. Kasi syempre, they are expected to have younger RBCs than adults. So mas mataas yung kanilang reticulocyte count. Okay? Next, we have the absolute reticulocyte count. So the absolute reticulocyte count, this represents the actual number, okay, of retics, okay, the actual number of retics per liter of whole blood. Okay, actual number of reticulocytes per liter of whole blood. Okay, so ano naman yung formula natin, no, for the absolute reticulocyte count? Okay, for the absolute count, so that is your reticulocyte count in percent. So that means that is your relative count times your RBC count, okay, divided by 100. Okay, divided by 100. So what is the normal value for the absolute reticulocyte count? That is 25 to 75 times 10 to the 9th per liter. Next, we also have the corrected reticulocyte count. Okay? So para saan, no? Para saan naman, no, yung corrected reticulocyte count? Sometimes, no, because of certain conditions, for example, yung hematocrit ng pasyente mababa. Okay? And because of that, because mababa yung hematocrit, remember guys that we are counting the reticulocytes in relation to or relative to our red blood cells. Okay? So it's really possible that if the specimens, no, the specimens, okay, have, okay, decreased hematocrit, it could result to a falsely high, okay, to a falsely high reticulocyte count. I'm referring to the relative one, no? Falsely high retic count. Okay? And thus, pag mababa yung hematocrit, we have to perform the corrected reticulocyte count. So what is our formula for this? Okay? Corrected retic. Okay? This is your reticulocyte count in percent, okay? Times your hematocrit, okay, in liters per liter divided by 0.45. Okay? So, what is the normal value? Okay, what is the normal value for this? Okay, the normal value for this depends on the hematocrit level of the patient. Okay? So if the hematocrit level of the patient, okay, is at least, no, 35%, dapat yung normal value niya for the corrected reticulocyte count is 2 to 3%. But if the hematocrit of the patient is less than 25%, then the normal value for the corrected reticulocyte count is 3 to 5%. And lastly, okay, we have the reticulocyte production index. Okay? Reticulocyte production index. So itong reticulocyte production index, guys, this is actually the type, no, or the modification of reticulocyte count that will actually give us the uh, give us the right information about our bone marrow response. Okay? About our bone marrow response. Remember, guys, no, that in cases, for example, of anemia, okay, if there is a need of red blood cells in the circulation, the tendency of the bone marrow is to release reticulocytes way earlier. Okay? So, remember guys na yung retic natin, may tinatawag sila na maturation time. Okay? May tinatawag sila na maturation time. So, if that maturation time usually depends on the hematocrit level of the patient. Okay? Kasi yung hematocrit, basically, that could also give us kung gaano karami yung RBC natin, 'di ba? In a certain volume of blood, 'di ba? So usually, pag yung hematocrit natin normal, normal din yung maturation time ng ating mga reticulocytes. When you say maturation time, gaano ba katagal namamalagi yung retic as retic in the peripheral circulation after it is being released from the bone marrow? My point here is, when a reticulocyte is released from the bone marrow, it will stay as a reticulocyte in the circulation for 1 day only. So after 1 day, it will now become a mature RBC. However, if yung reticulocyte nilabas ng bone marrow earlier, it will stay longer as reticulocyte in the circulation. Okay? I hope you are getting my point here. Kasi mas maaga siyang nilabas ng bone marrow, tatagal siya bilang reticulocyte in the peripheral circulation. Thus, the maturation time increases in relation to the decrease in your hematocrit value. Okay? Tawag natin dito guys sa mga reticulocytes that are being released earlier, we call them as shift, no? Shift reticulocytes. Okay? Shift reticulocytes. So they are the reticulocytes that are prematurely, no? These are the reticulocytes that are prematurely released, okay? Released into the circulation. Okay? And because of that, they are staying longer as reticulocytes in the circulation. So what is the formula for the reticulocyte production index? RPI is your corrected reticulocyte count. Okay? Corrected reticulocyte count. Okay? Divided by your maturation time in days. Okay? So the maturation time depends on the hematocrit value of the patient. Okay. Now, if your reticulocyte production index is greater than, okay, if your reticulocyte production index is, let's say, greater than 3%, okay, that means your bone marrow is adequately responding to anemia. But if the value is less than 2%, therefore the response is, the bone marrow response is inadequate. Okay. The bone marrow response is inadequate. Okay, so let us now proceed to erythrocyte sedimentation rate. Okay, so ESR is a non-specific measurement used to detect and monitor an inflammatory response. So this one actually is a bit sensitive, however, it is non-specific. So this is based on the distance that is being settled by red blood cells in milliliters within 1 hour. Okay, so I have enlisted here the different factors that affect the ESR result and classified them on what are the factors that will decrease. Okay, that means that will slow down, okay, the settlement of the red blood cells, and those factors that will increase, okay, the settling of the red blood cells. Okay, so first we have the red blood cell factors. Okay, So to make it really simple, okay, when it comes to the RBC, the larger the red blood cells, the faster they will settle. Okay, so which is why nandito no yung ating mga microcytes, okay? Microcytes, because they are small, they will settle slower as compared to the macrocytes, of course. Okay? Now, in cases of anemia, why is it that the ESR is decreased? Rather, the ESR is increased. That is because of your lower hematocrit value. So because the hematocrit value is lower, the red blood cell column that will form, okay, after 1 hour is kumbaga mas maliit, no? That is because of the lower amount or the lower hematocrit value. Okay? Decrease kasi yung hematocrit dito. Okay? In cases of anisocytosis, poikilocytosis, okay, of course, the variation in the size and the variation in the shape of the red blood cells would make it difficult for them to form Rouleau formation, which is, of course, very important, okay, when it comes to erythrocyte sedimentation rate. Okay? For polycythemia, of course, the explanation is the opposite of anemia. If you have polycythemia, your red cell mass is high, okay, and that makes, or that would create a taller, okay, a red blood cell column, okay, after 1 hour settling of the red blood cell. Next, we have the plasma factors. The plasma factor, sa katunayan, okay, is the single and most important factor that determines ESR. Okay, so take note natin dito. This is the single, okay, and most, okay, most important factor, okay, that influence erythrocyte sedimentation rate. Okay, so usually this is influenced by the different proteins that are present in our plasma. Okay, now we have here albumin. Okay, so albumin, why is it that albumin is decreasing ESR? As what I've mentioned, Rouleau is very important for ESR to for sedimentation to happen. And the thing about albumin, remember that albumin is responsible for the zeta potential. Okay, this is the force. Okay, the zeta potential is the force that makes our red blood cells repel each other. And that means, okay, your albumin basically will prevent Rouleau formation. In contrast, fibrinogens and globulins, these are proteins that are actually decreasing the zeta potential. And these are proteins that are promoting Rouleau formation, okay, and thus increasing ESR. Okay? Another, and I think the most important thing dito natatandaan natin are the technical factors, because again, in ASCP, usually they are asking about erroneous results. They are asking about how a particular test is being influenced, no, by certain technical factors, and how would you do a remedy about it, di ba? So first, for the technical factors, what are the technical factors that will decrease, okay, that will decrease ESR? So we have here delay in testing, okay? So when you say delay in testing, you are not able to perform the procedure right away. And if the testing is delayed, the thing about that is when the testing is delayed, the red blood cells are exposed to the anticoagulant for a longer period of time. And that exposure to the anticoagulant will make the red cells crenate. That is the same reason for over anticoagulation. So since the red cells are crenated, okay, if the red cell membrane is no longer normal, that also would prevent Rouleau formation. Okay? However, important dito, be vigilant in the questioning, because sometimes yung tanong nila is delay in reading. Okay? Delay in reading. Now, if delayed naman yung reading mo, 'di ba, you are supposed to read the result after 1 hour or after 60 minutes. If you are not able to do that, of course you are giving more time for the red cells to settle. Therefore, delay in reading will increase ESR. Okay? So, delay in reading, okay, will increase ESR because you are giving them more time to settle. So, that means also that if you read the result before 60 minutes, that would decrease the ESR also. Okay. Next, for the technical factors that will increase, we have the tilting of the tube, okay, the increase in temperature, mechanical vibration, and the length of the diameter of the tube. Okay, so just take note of these factors. Okay, now let's go to lap staining or the lap score. So lap staining is an important technique, no, especially for the differentiation of certain conditions. So commonly this is employed to differentiate yung chronic myelogenous leukemia versus the leukemioid, okay, versus the leukemioid reaction. Okay? So in this particular technique, what you are staining here is the alkaline phosphatase that is actually present in neutrophils, and to a small degree present in certain B lymphocytes. Okay, so this particular alkaline phosphatase is only present in the mature forms of neutrophil. Okay, so the specimen of choice here is fresh capillary blood, but alternatively, we could make use of blood collected using heparin as an anticoagulant. So the procedure involved here is the Kaplow count, wherein we are counting 100 neutrophils. Take note, we are only counting the neutrophils, and we are scoring their staining intensity from 0 to 4. Okay? So, parang nagpe-perform ka lang din dito ng differential count. It's just that what you are classifying here is the staining intensity of the neutrophils. Okay? So, all you have to do is to grade them from 0 to 4 plus. And for you to solve the lap score, all you have to do is to multiply the grade and the number of the cell counted. So for example, in this problem, so what will be the lap score here? So 1 times 50, so that would be 50. Ito 2 times 30, that is 60. 3 times 10, that's 30. 4 times 10, that's 40. Then all you have to do is to total all of these scores. So 50 plus 60 plus 30 plus 40, that gives us 180. So this is now your lap score. Okay? So ganun lang naman kadali, no, yung lap scoring. So take note, no, na neutrophils lang yung binabasa natin dito. Because sa katunayan, there is a recall question in the ASCP exam. It's a problem wherein the medtech daw is performing lap staining, and he noticed that there are a lot of eosinophils present in the smear. Ano daw yung gagawin ng medtech? Guys, wala lang, no? All you have to do is to ignore the eosinophils, because technically what you are focused on are the neutrophils. Okay? So here are the differentials. Okay, wherein lap score is normal. So as what I've said, it's most commonly used to differentiate leukemioid reaction versus chronic myelogenous leukemia, wherein CML will have a decreased lap score and leukemioid reaction will have an increased lap score. Okay, so yan po. And I think this is the last for our laboratory techniques, and this is very important, no, especially in the recent exams, no, exam passers na nakapagbigay sa akin ng feedback of the exam. There are already a plenty of questions about immunophenotyping, wherein you are given a result of flow cytometry and you are to identify the condition. So it's very important na alam natin on what are the different clusters of differentiation present in a certain cellular population. Okay, so this is a very significant or important tool in diagnosing malignancy in the blood, no, or blood malignancies, no, especially yung mga leukemia. So nagagamit natin ito in subclassifying leukemia. Okay, so for our acute myeloid leukemia, we are already done with this topic, and I think I already have emphasized on what are the different CD markers that are present for a certain type of AML. Now, for our acute lymphoblastic leukemia, okay, so of course that would depend on what lymphocyte population is affected. So we have here the B cell, no, ALLs, the T cell ALLs, and I have selected specific lymphomas here. Okay, so for the B cell ALLs, if it is an early precursor B cell ALL, what are the CD markers that we are going to expect? Okay, so we have CD34. Okay, we have CD19. we have the TDT, kasi alam natin that lymphocytes will really stain positive for terminal deoxyribonucleotidyl transferase. This is a terminal, okay, terminal deoxyribonucleotidyl transferase, okay, kung saan nagpa-positive yung mga ALLs natin. And of course, we have the HLA-DR. Okay? So since this is an early precursor, okay, if you would observe, nandito yung CD34. Kasi alam naman natin that CD34 is a hematopoietic stem cell marker. So that is usually present doon sa mga immature cells talaga. Okay? Next, we have intermediate pre-B cell ALL. So what are the markers found here? We have CD10, okay? We have CD19, okay? We have the HLA-DR, okay? We have TDT, of course, okay? And sometimes, no, sometimes pwede pa rin tayong makakita ng CD34, but not as frequent, no, as compared with the other markers. So kaya lalagay ko siya dito sa dulo, no, kasi hindi siya ganun ka-indicative talaga. Okay? So lagay natin, sometimes pwede tayong makakita ng CD34. Next, for the pre-B cell ALL, okay, we have CD19, okay? We have cytoplasmic immunoglobulins, okay, cytoplasmic immunoglobulins. We have HLA-DR, we have TDT, okay? Okay, TDT, sorry. We have TDT, we have CD22, and sometimes pwede tayong makakita ng CD10. Okay, sometimes. So take note na yung CD34, okay, is most significant for the early precursor. Yung CD10 is most significant for the intermediate pre-B cell ALL. Okay? Now, for our T-cell naman, of course, we are to expect yung ating mga T-cell markers. Di ba? Parang may mnemonic tayo dito na yung mga B daw, big numbers, that is for the B-cell population. Tapos yung mga small numbers, T, tinatandaan nila dito tiny, kasi small. So yung mga small numbers, that is for the T-cell population. So we have CD2, okay, CD3, okay, CD4, if the involved ones are the helper cells, okay, we have CD5, CD7, CD8 for the cytotoxic, and of course, we have the TDT. Yeah. Okay? Now, here are the immunotype of selected mature B-cell neoplasm. So, lagyan ko siya ng star. Very important in the exam. Okay? So, first, we have here CLL. So, CLL is chronic. Okay? CLL is chronic lymphocytic leukemia. Okay? So, for CLL, you'll have a very high positivity for CD19. Positive ka din sa CD20. You might be positive or negative for CD79A, positive for CD5, positive for CD23, okay? Negative for FMC7, okay? Positive for CD11C, negative for CD25, negative for CD10, and you might be positive or negative for surface immunoglobulins. Okay? Next, for MCL, MCL is mantle cell lymphoma. Okay, this is mantle cell lymphoma. Okay, so for mantle cell lymphoma, giging positive ka for CD19, mataas din yung positivity for CD20, positive for CD79A, for CD5, negative for CD23, positive for FMC7, okay? Negative for CD11C, negative for CD25, negative for CD10, and you will have surface immunoglobulins. Next, we have FL, or the FL means follicular lymphoma. Okay, follicular lymphoma. So for follicular lymphoma, okay, you will have positive or at least not trace reaction for CD19. Okay, a strong reaction with CD20, positive for CD79A, negative for CD5, positive for CD23, okay, positive for FMC7, negative ka for CD11C and CD25, positive for CD10, and presence of surface immunoglobulins. Okay? And lastly, we have the MZL. MZL is the marginal zone lymphoma. Okay? MZL is the marginal zone lymphoma. Okay? Or tinatawag din ito guys na pwede din siyang tawaging SLVL. SLVL means splenic, okay? Splenic lymphoma. Kasi yung marginal zone, 'di ba, nasa spleen yan. Splenic lymphoma with villous, okay? Villous lymphocytes. Okay? Splenic lymphoma with villous lymphocytes. Okay? So for MZL, positive tayo for CD19, positive tayo for CD20, positive for CD79A, negative for CD5, negative for CD23, okay? Positive for FMC7, okay? Positive din for CD11C, okay? Pwedeng positive or negative for CD25, negative for CD10, and you'll have presence of surface immunoglobulin. Okay? So of course, I know this is really a bit challenging for us to be able to memorize all this, no? But I hope you focus on those that will really differentiate one lymphoma from the other. Okay? Kasi very useful to, no, when it comes to elimination in the actual examination. Okay? So this is a high yield concept in the exam. So wag talaga tong kalimutan, ha? Wag kalimutan itong ating mga immunophenotyping markers. Okay? So I think that ends our session for the last part of hematology. Okay? So we will have a different session, no, because in the specifications of the ASEP, parang single out nila or sineparate nila yung hemostasis. Okay? So that ends our hematology lecture series. Okay? Maraming salamat, everyone.